Just a reminder, this event will be recorded, so you can watch it at another time, and hopefully it'll help anyone who we lost during the transition to this new link. So I'm Dylan Roby. I'm a new associate professor at UC Irvine in the program in public health. I'm in the Department of Health, Society, and Behavior, and I also direct the new division of health policy. And so today, to kick off Public Health Week, I'm going to talk a little bit about what California is doing in terms of expanding insurance coverage to undocumented immigrants in the state, kind of what progress has been made up to this point and what is in store in the future, and also think through some of the issues there. So thanks all for joining. I hope we have some time at the end for questions. Because we're no longer in the kind of webinar format, it should be easier to kind of have a conversation about this stuff. So please feel free to put your questions in the chat. And I will do my best to field them, and Amanda, our moderator, will as well. So quick summary of today's talk. We'll focus today on efforts in California to provide health insurance to undocumented immigrants in the state of California. Thinking about residents of the state being anyone living in the state, not necessarily having any sort of lawful permanent resident status or citizenship status. That's a key issue here. In California, even though it's one of a handful of really liberal states, is a trailblazer in this effort. New York is really considering an option led by folks like the New York Immigration Coalition and other advocates. I think California is the first to take really concrete steps to allow undocumented immigrants to enroll in Medi-Cal using state dollars, and they've done it in a kind of systematic, phased-in way. And it's part of a larger Health for All strategy that's been pursued by policymakers in California, as well as advocacy groups like Health Access and other coalition members. So the other thing to think about in California is we have this overlay of existing county programs that support the indigent care needs of the population that resides in a specific county. Of course, the level of support in those counties differs depending on where you're living. So in a county like Orange County, we actually don't have coverage for undocumented immigrants, whereas in LA County, there are programs that undocumented immigrants are actually eligible for, and they're provided with care in a systematic way. So if you're in San Francisco or LA County, undocumented immigrants are allowed into those county indigent care programs like Healthy San Francisco and My Health LA. But in Orange County, our medical safety net program, or let's say San Diego County, they're excluded from participation because of that documentation status. So this expansion could have different impacts on people's health depending on the county where you live. The governor's proposed budget includes an expansion of this Medicaid funding for adults aged 26 to 49, so that all low-income people in the state would have access to Medi-Cal by January 1st, 2024. So if we kind of think about undocumented insurance coverage overall, there are 2.3 million undocumented Californians, representing about 6% of the population. That doesn't necessarily mean that all of them are uninsured. There are quite a few that have access through other programs, including the off-exchange individual market. So you can buy coverage outside of covered California using your own dollars, but undocumented immigrants are excluded explicitly from buying coverage through covered California or taking part in tax credits or cost-sharing subsidies there. Undocumented immigrants could also have employer-sponsored insurance coverage through their employer. And I would say roughly half of the insured undocumented immigrants probably have ESI coverage, employer-sponsored coverage. So if we think about the Affordable Care Act and its expansion of insurance in 2014, it really expanded coverage to people who are not undocumented, so people who are lawful permanent residents or were citizens. California took a somewhat unique approach in that federal law basically says that Medicaid is only open with federal dollars to lawful permanent residents who have had a green card for more than 5 years. So it's called the 5-year eligibility bar. So in most states, if you are a lawful permanent resident with a green card, but you haven't had your green card for 5 years, even though you might be under the poverty level, let's say, you would only be allowed to go buy coverage in the insurance exchange in that state, and you would be entitled to tax credits and cost sharing reductions to support your purchase of that coverage, but you wouldn't be allowed in Medicaid. In California, the state decided in 2014 to facilitate Medi-Cal coverage for those folks with state dollars. So knowing that the federal government wouldn't put up any matching funds for them, the state just decided to make it cleaner. We will provide coverage to people under the 5-year eligibility bar, even though they don't meet the federal definition of Medicaid eligibility, and pay state dollars. So it's kind of a similar model that was used with the undocumented population later on in 2016 and beyond. So Covered California, the insurance exchange, provides these tax credits and subsidies, but if they're only to citizens and lawful permanent residents, you kind of could miss out on the undocumented population. So that's why the undocumented end up in the off-exchange individual market, the employer-sponsored insurance market. The documented recent immigrants end up in Medi-Cal or in the exchange, and the documented more than 5-year recent immigrants would be in Medi-Cal as they typically would, or in the exchange coverage, because there's no differentiation in the ACA between citizens and lawful permanent residents who have lived in the US for more than 5 years with a green card. So just to get at kind of the issues around how the transition might work with county safety net programs, there's likely to be uneven impacts throughout the state, depending on how robust or what the eligibility criteria for county safety net programs was for the undocumented population. So there are 2 examples here. So just to back up a little bit, California requires in the Welfare and Institutions Code, section 17,000, that every county will have a program to support healthcare for the indigent who cannot afford coverage and are not eligible for other programs or haven't signed up for other programs. So every county must comply with this Welfare and Institutions Code requirement, and it's kind of been tested by lawsuits over the years. But the counties are allowed to differ in terms of eligibility guidelines and also who they cover. Their definition of residence can differ quite a bit. So for example, in LA County, if you can produce an address in LA County, even if you're undocumented, you qualify for the My Health LA Indigent Care Program. If you're in Orange County, if you're undocumented and you don't meet certain criteria, like meeting the persons residing under color of law rules or temporary protective status or something like that, you wouldn't be allowed into the Orange County Indigent Care Program called the Medical Safety Net Program. This matters a little bit in terms of not only exclusion, but also where people go to get care. So in My Health LA, in LA County, they have decided, all right, we're going to create these eligibility criteria. We're going to screen people for eligibility. If someone is undocumented, they will be submitted to Medi-Cal for an eligibility determination, but it may be that they qualify only for restricted scope emergency Medi-Cal temporarily when they show up in an ER or when they need an inpatient hospital stay related to an emergency room visit. So that window of eligibility under Medi-Cal would last 30 days, let's say. But all of their other care could be delivered through My Health LA as this county safety net indigent care program. And LA County has decided, okay, we're going to use the federally qualified health centers, county clinics, and a network of private partners to assign people a medical home that they use for primary care and preventive services. And then if they need specialty care or hospital stays or emergency room visits, they will go through the LA County public hospitals and county specialty centers. So the county tries to organize and finance the entire kind of continuum of care for a set of eligible benefits and services for the population, regardless of whether they're documented or undocumented, or regardless of kind of income up to a certain level, usually around 300%, 350% poverty, depending on the situation. Now, in Orange County, on the other hand, we have a restriction on the undocumented participating in that county safety net program, because Orange County has decided to put their Welfare and Institutions Code section 17,000 program together in a way that excludes the undocumented, but includes other recent immigrant groups and other citizens and non-citizen but lawful permanent residents who may be eligible for Medi-Cal or other programs, but didn't sign up for some reason. Or they may be ineligible for Medi-Cal and unable to sign up for Covered California or something like that. So in essence, they have a more restricted eligibility set, but they also have a more restricted set of services covered by the program. Now, Orange County doesn't have a public hospital like LA County does. So that changes the calculus quite a bit, where the county enters into a contract to support their indigent care program, the medical safety net program, by contracting with a public-private partnership of clinics and hospitals. So all of the nonprofit hospitals in Orange County are part of this program, and they're getting reimbursed by the county for certain services that fall under the jurisdiction of the medical safety net program. However, undocumented immigrants aren't included in the eligibility criteria. So you would have a hospital like UCI Health, for example, who might have someone come through the ER, and if they are an undocumented immigrant, they would not be eligible for or billable to the county safety net program. If they were a documented immigrant or a citizen, they would be eligible and billable to the county safety net program. But the safety net program doesn't include preventive services. And so there are needed services that might be provided through the program, but a lot of the other burden falls on the actual hospital settings because they are still contending with things like the Emergency Medical Treatment and Active Labor Act and TALA, where they have to stabilize people coming through the ER. They might also be providing charity care, billing people who are uninsured with, and incurring bad debt, or requiring people to self-pay for services. So I guess the downside risk for a resident in Orange County using the county safety net is greater than maybe in LA County, because you could end up with a large bill. You could end up having to apply and hope to get coverage through a charity care program, or perhaps in some cases, if you're a citizen and if you're a documented immigrant with legal permanent residence, you would be able to use some services that are considered necessary by the county program, but it wouldn't be as comprehensive in terms of eligibility or benefits as the LA County program. So in terms of kind of access and outcome evidence, I want to review some of the basics here in terms of what we know about the undocumented when using care. And so if we look at access and outcomes, the undocumented are less likely to have a usual source of care, less likely to go to the doctor, less likely to use the emergency room than their US-born Latino counterparts who are either uninsured or on Medicaid in many cases. And this has been supported by both Alex Ortega's work and also Michael Rodriguez's work at UCLA using California Health Interview Survey data and also administrative data to analyze these issues. I think that these findings do kind of fly in the face of the common misperception that undocumented folks or uninsured folks are clogging up the ER using unnecessary care. Instead, it actually turns out that insured patients use ER care at a much higher rate, even though we may see a disproportionate share of uninsured people using the emergency room for their care. They actually represent a very small proportion of all the emergency room care we see. And part of it is because of the risk they face in terms of paying for that care if they don't have insurance coverage. So there's this barrier, a cost and access barrier, that keeps people who are undocumented and uninsured from using healthcare, and that can lead to a longer term poor outcome. So in terms of outcomes, the undocumented are more likely to report a negative experience. They're less likely to get healthcare information from a doctor. They're less likely to self-report excellent or very good health. But they also tend to be a little bit healthier, at least in these two papers from a newer paper from Alex Ortega, which I'm a co-author on, as well as Michael Rodriguez, showing that health status is a little bit better on certain things like overweight, hypertension, reporting psychological distress, or needing behavioral health services. Recent work from Annie Rowe at UCI found that hospitalized younger undocumented patients have less severe illness than their counterparts in Medi-Cal, and they have a shorter length of stay. Once you get to older patients who are undocumented, they also have less severe illness, but they have more repeat hospitalizations because of access barriers potentially. So, I don't think we should be as concerned as kind of pundits make it out to be, or some groups say in terms of the use of ER care or primary care by undocumented immigrants. They use a lot less than their counterparts who are US born, and they use a lot less than their counterparts who are insured already. Now, one would then postulate that once somebody gets healthcare coverage, they're more likely to use needed services. And so we have to make sure we're aware of that. But I think there are appropriate needed services that will then be facilitated by having access to coverage. And if we look at the benefits of insurance coverage, I think if you look back at like the Oregon Health Study, the Rand Health Insurance Experiment, and other recent studies, I think the the argument that President Obama made in passing the ACA about, well, if you have insurance coverage, you won't need emergency room care anymore. You'll always use primary care. That hasn't borne out to be true. And, that's been shown in the health services research literature for years, that when you have insurance coverage, you use more services. But we do know there's some positive outcomes like reducing financial distress, limiting out-of-pocket spending on healthcare, allowing for earlier diagnosis of chronic conditions, increasing preventive service use, and reducing preventable mortality. That being said, people who get health insurance coverage, especially in the short term, are often seen to use more services to kind of catch up on care that has been delayed or foregone. And then once they have stabilized, they go back down to a more normal level. And so we might expect in any expansion of insurance, whether it's the ACA with documented immigrants and citizens, or the Medi-Cal expansions, you would end up seeing higher use of services by those populations temporarily, and then we'll reach some level of equilibrium. So any program should be aware of those issues when they're kind of budgeting and planning. So some of these findings are related to work we've done that I'm part of at UCLA and UC Berkeley. We have a simulation model called CalSIM, the California Simulation of Insurance Markets Model, and started back in 2007 to respond to the governor's attempts at health reform, which of course failed, but kind of set the stage where an individual mandate was kind of acceptable to many healthcare advocates, and was built on in the 2006 Massachusetts reform, also known as Romney Care, and then in 2010 Affordable Care Act. We've been contracted to model impacts of the ACA for Covered California, and we continue to get funding from Covered California and the California Endowment to support estimates of impacts of various reform efforts that are on the horizon. So in this case, we have done some work to evaluate the likely impact of the Medicaid expansion to the undocumented immigrant population of these different age groups. CalSIM is a dynamic model that basically incorporates individual characteristics from the Medical Expenditure Panel Survey and the California Health Interview Survey, tries to assess a utility that helps us predict what decision someone may make in the face of what decision their employers are making at the same time about whether to offer them insurance coverage based on a bunch of other factors, including unemployment rate, industry and workforce competition, penalties levied by the ACA for not offering coverage, and the utility to their overall workforce. And so we have this iterative process where people are making hypothetical synthetic decisions in response to what their employer does related to the ACA, but also new options that come up in state health insurance reforms. So we'll be having a forthcoming policy brief that'll cover a lot of these findings on April 14th. And I'm going to share some kind of estimates from that brief that are preliminary and that will be released for prime time April 14th. And you can find the brief and more information on the methods at calsim.org. So if we look at, there's a previous version of CalSIM, we found that 3.2 million Californians were destined to be uninsured in 2023, absent any other policy change. 64% of these uninsured folks were Latino. And of course, not all of them being undocumented, but a large portion of the undocumented population in the state is Latino, but so are a large portion of people who are eligible for subsidies in Covered California and do not take it up, eligible for employer-sponsored insurance and don't take it up, and eligible for Medi-Cal, but for some reason don't enroll. So you can see here that of the 3.2 million uninsured, only about a third, a little bit over a third, are undocumented. So there are lots of people that are sitting on the sidelines for some reason, either because they can't afford insurance coverage through Covered California or off of Covered California, they don't perceive a need or can't afford insurance coverage through their employer, or they're eligible for Medi-Cal, but for some reason don't sign up, maybe due to information gap or because of other kind of issues related to Medi-Cal benefits. So the policy option that's being put forward by kind of the Health for All advocates has been to try to use Medi-Cal with state dollars, leveraging some federal dollars for emergency Medi-Cal to enroll kids in coverage, and then seniors, and now the rest of the adult population that has been left out. So in 2016, the Health for All Kids bill passed, which facilitated Medi-Cal enrollment for kids age 0 to 18 in Medi-Cal using state dollars. Then in 2019 budget, the 19 to 25-year-old expansion passed. So as of 2020, we had anyone from 0 to 25 who was undocumented, earning less than 267% of federal poverty level for the 0 to 18 population, and up to 138% of poverty level for the 19 to 25-year-old population was allowed into Medi-Cal. So that was the undocumented expansion that happened in 2020. Last budget cycle, a budget was passed that included funding for anyone age 50 and over who is undocumented and earning under 138% of poverty to join Medi-Cal. That will go into effect May 2022. So next month, if you're over 50, undocumented, and earning less than 138% of federal poverty level in California, you can apply and be enrolled into Medi-Cal. Then in the February budget outline that the governor put out, he proposed for this year's budget, subject to revision, of course. So every year we have a February budget come out, and then we have the May revision, or the May revise, as they call it, that will be released in May. The idea to cover undocumented immigrants aged 26 to 49 that have historically been left out of other coverage options would take place January 1st, 2024. So if the budget passes, or if the May revision still includes this provision, and the budget passes through the legislature and is passed this summer, the idea would be that people would be transitioned into full scope Medi-Cal if they're age 26 to 49, and we would end up with a Medi-Cal program by January 1st, 2024 that includes eligibility for any undocumented group in the state of California. So the first expansion from 0 to 18 covered about 126,000 people. Then the next expansion of 19 to 25-year-olds included about 96,000 people. So at this point, we have a little over 220,000 people who are undocumented previously, or who are undocumented, previously uninsured, who moved into Medi-Cal. Then in this expansion that's occurring in May, it's estimated to include about 235,000 people who would be able to sign up. And that's a total of 457,000 people that have already been approved to join Medi-Cal and enroll in Medi-Cal, even though they're undocumented, and partially funded, but mostly funded by state dollars. So if we think about the proposed expansion for 26 to 49-year-olds, it would occur January 1st, 2024. The total budget ask is $2.4 billion per year to fund this expansion. So for those roughly 700,000 to 930,000 people who would likely enroll in Medi-Cal based on either the CalSIM estimates or the Legislative Analyst Office estimates of who would likely take up coverage. They would then join Medi-Cal, and they're estimated to cost about $2.4 billion per year. 2.1 billion of that will come from state general fund dollars. The other 0.3 billion is coming from kind of pass-through dollars from the federal government, because some of these folks were in emergency Medi-Cal. And so when states expand coverage to undocumented immigrants, they can often get credit from CMS for the Centers for Medicaid Services on kind of the cost that they would have incurred in emergency Medicaid, which the federal government does provide matching funds for, to help pay for the comprehensive coverage. So the argument being, right now, we're often just kind of episodically treating people through Medicaid and reimbursing their providers for emergency room care for 30 days, when you could actually use that money, repurpose it, and fund it a more comprehensive, full scope Medicaid program that would include people throughout the year, get them a medical home, assign them to a managed care plan, and they would benefit from the integration that Medicaid would provide, rather than being this very episodic emergent care safety net. So the uninsured rate would go down further from about 10% now to 7%. The disparity for Latinos as uninsured would narrow quite a bit, because the majority of undocumented immigrants in California are Latino. And we would probably see, if up to 930,000 people enrolled, a large decrease in the 2.3 or 3.2 million people who are uninsured right now, with almost 1.16 million being undocumented. You would anticipate that that number would shrink quite a bit. The CalSIM estimates are a little bit less generous than the LAO estimates. One of the reasons for that is the LAO said we think that a lot of the people who will be eligible for this expansion are already in emergency Medi-Cal. When CalSIM makes estimates, we kind of look at the historical evidence around the ability for different populations to enroll. And so we discounted that quite a bit in making our estimate. So people currently in that emergency Medi-Cal might move over, obtain full scope. There might be people new to the system who haven't been in emergency Medi-Cal, but are undocumented and meet the income eligibility who would also obtain full scope. They would be assigned to a Medi-Cal managed care plan, and they would be kind of mainstreamed into Medi-Cal. And in theory, even that if that leads to short-term increases in utilization, it would stabilize over time as people had their healthcare needs addressed, and we would move a step closer to kind of having universal coverage for at least low-income people, regardless of immigration status in the state of California. The other thing that's going on is, of course, the CalAIM waiver, which is designed to kind of address some of the social determinants of health, including homelessness and transitions from incarceration. And that could also be aligned with this expansion of Medicaid, where the system will seem less fragmented to people who are actually using it. So in conclusion, while the proposal doesn't achieve universal coverage, it would expand it greatly. I mean, this would be the largest expansion in insurance coverage in California since the Affordable Care Act's passage and implementation, with potentially up to 900,000 people signing up, more likely something around 700,000 people, depending. But it would also provide the safety net where Medi-Cal, unlike individual market coverage, you can sign up at any time, right? So we often catch people in Medi-Cal who qualify when they are using services at the point of service through a federally qualified health center or through an emergency room, and you could facilitate transition into this Medi-Cal program rather than waiting on open enrollment. So it fits well with low-income populations who may not be aware of the expansion, but could benefit from it greatly. The focus really has been on low-income Californians, though, and we still have some work to do to ensure that people can afford premiums, potentially continue with state dollars or hopefully federal dollars, the subsidies made available through the American Rescue Plan Act. And we still have to address some of these issues with communication, affordability, and fragmentation. Like the fact that we have to think about this population ends up in Medi-Cal, this population ends up in Medicare, this population ends up in Covered California with tax credits, this one ends up there without tax credits. All of that is a big, hassle for consumers to figure out where they belong. And we're always doing these incremental changes to improve people's access to care. And, it'd be nice to consolidate it a little bit more and make it more efficient. This implementation will be concurrent with other attempts to remove barriers. So it's possible that you will see a better response to these sorts of expansions because of the fact that the Medi-Cal asset test is being phased out starting in July 1st, 2022, and will be completely gone by July 1st, 2024, where people used to be able to have only about $2,000 in savings to qualify for Medi-Cal, and that's been increasing. That's going to increase to, I think, $140,000 in July 2022, and then be phased out ultimately by 2024. So the asset test is no longer a barrier for people who are at lower incomes. And of course, the CalAIM reforms and the waiver and all the focus that DHCS will have on social determinants will also be helpful. And I think in the vein of Public Health Week, I think we've become a lot more aware of the fact that people not having insurance coverage, not having access to regular sources of care is really dangerous in a pandemic. And there are public health risks and future pandemics that could be addressed partially by ensuring that everybody has insurance coverage, because we can use insurance coverage as an avenue to make sure people have ability to get tested, treated, and facilitate care for them after a diagnosis, rather than kind of seeing the disparities we saw in the COVID-19 pandemic related to undocumented populations, Latino populations, and Black populations, where essential workers were very much put at risk and they had less access to the things that would keep them healthy, including regular testing and treatment because of insurance coverage. And when we have, like the Biden administration, for example, trying to use insurance as a way to facilitate access to testing, like the fact that they said, okay, well, we have 4 tests a month per family for that can be received for free through the US Postal Service. But if you want, you can get 8 tests per person in your family. However, you must have insurance coverage. You must purchase the test on your own and then file for reimbursement as a claim through that insurance coverage. Means that there are reasons to have that that safety net of insurance coverage to enable people to actually get access to some of those services. And if the Obama administration, I mean, the Biden administration was, they were facing a difficulty in getting a deal that would provide comprehensive testing, and they tried to use insurance as a way to facilitate testing. Using that method leaves out a large part of the population that's at high risk. So I think we need to think about how health insurance should be supporting public health and social policies, as well as just acting as health insurance for more acute conditions. So I will leave it at that, and I'm happy to answer any questions from the audience. We have about 10 minutes left in the session.
Looks like Tiffany has a question.
Yes. So I know you mentioned that this would mostly be covered by the federal government. Where is the rest of the funding coming from?
So it's actually mostly covered by the state government. So out of the 2.4 million a year, billion a year, 300 million will come from the federal government through matching funds. The rest will be state funded. It is coming from the general fund, so basically tax revenues and the state budget. The argument in the past has been, we don't have the money to do this. I think the fact that we had this, huge budget surplus this fiscal year that is forecast to continue gave Governor Newsom and other advocates kind of the ability to push forward with it. In past cycles, like Kevin De Leon had introduced a bill years ago, and the costs were too much. So if you think about the governor's budget process, if the governor puts it in their budget outline, it's a lot easier to get through the legislature. The problem with that, of course, is if the governor puts it in their budget outline, it means that the budget committees are dealing with the bill, not the policy committees. So the health committee is kind of sidelined by putting in the governor's budget. In this case, it's helpful in a way because anyone who's a supporter on the health committee likes the fact that the governor has already earmarked money in the budget for this, and they don't have to fight for an additional budget allotment or to cut a program or raise taxes to fund it. So in this case, it works out very well for Democrats in the legislature who have been trying to support this for years, because the governor has already allocated money in the budget for it, and they don't have to generate new revenue as part of a bill, which means they also don't have to deal with a 2/3 supermajority to pass their policy bill out of a policy committee and get a budget allocation. So it's mostly coming from the surplus and the forecasting that the governor's office is doing, but it is helpful to Democrats in the legislature who are supportive to have it on the governor's side of things and already built into the budget outline, rather than having to generate the budget internally through their legislative bill and then somehow get the governor's office to agree. And we've seen cases where, Kevin De Leon years ago had to, I think, shelve the undocumented expansion bill twice because of this lack of budget authority and inability to get agreement on paying for it. So I have a question from Carrie Mitchell around how is PRU-Call Medi-Cal funded. So PRU-Call is persons residing under color of law. One could argue they are considered an undocumented part of the population from a green card standpoint. However, because they have been, the government is viewed as being aware of them and not deporting them, they are then protected in a way. So for example, if you have an undocumented immigrant who's been living in the US and they file an application to become a legal permanent resident or a citizen, the federal immigration officials now know that person exists, lives in California, and is attempting to change their status. And that gives them what's known as PRU-Call, which is persons residing under color of law, meaning if the federal government isn't actively trying to deport you, you are a known immigrant. And even though you don't have legal status, you're kind of not being touched by the federal government. So Pru-Call is not technically Medi-Cal funded. However, many county programs, including Orange County, include Pru-Call in their definition of who is eligible. So if you're an undocumented immigrant in Orange County and you apply for the medical safety net program and your Pru-Call, so meaning you have a kind of a protected status in a way with the county where you would be eligible as a resident of Orange County who's in Pru-Call status. Whereas if you had not filed for adjustment in your immigration case, you would be viewed as undocumented, non-Pru-Call, and they would tell you, no, you're not eligible for the program. So it's a very kind of nuanced distinction that immigration lawyers know far more about than I do, but it is potentially protective because of the fact that you're known to the state government or known to the county government, and because there's no action to deport you, you may benefit from additional eligibility criteria that other undocumented immigrants may not. But it's definitely not as protective as something like TPS or kind of a refugee status. So.
Thank you.
Were there any other questions that folks had right now, or we can always address something later on after this presentation?
Hi, Dr. Roby. It's Heidi. I have a
Hello.
question. I'm not sure if it's sort of related or surrounded by it, but my question is, do you think the new proposed expansion will impact the inventory of healthcare providers? For instance, many providers are not accepting Medi-Cal and are inclined to be open to accepting PPO people.
Right. Yeah. So, I mean, I think that is a concern. Anytime we expand Medi-Cal, if Medi-Cal managed care plans are not compensating their network providers well, or we have a poor Medi-Cal fee schedule and providers are unwilling to accept Medi-Cal for everyone else in the program, and then you add on another 1 million people, what does that mean for Medi-Cal providers? So yeah, I certainly think that's an issue. And there's some evidence that even when people get Medicaid coverage, they still face access barriers where they're still not able to get a usual source of care, and they're not able to make an appointment quickly with a provider and have needs met. They still are financially protected, right? Because if they need to get care, it will often be provided, let's say through an emergency room or federally qualified health center or urgent care clinic. If they end up in the hospital with an exacerbation, it's covered. So they have financial protection, but their health status doesn't benefit, and they are not able to use a doctor as much as they would if they had private insurance coverage. So I think, the Newsom administration has kind of been implementing part of a proposition related to expanding Medicaid reimbursement, but it covers a certain set of procedure codes that are increasing. So in theory, primary care access should be getting better for Medi-Cal beneficiaries, but specialty care is still very poor in terms of access for Medi-Cal beneficiaries. And it kind of depends on what plan you're enrolled in. So if you're in LA Care, for example, and they have the large LA Care IPA, but they're not paying very well in terms of reimbursement, then you may have poor access. If you're in San Mateo and you're a member of the San Mateo health plan, and they're known to do a better job on reimbursement, then maybe you do have better access. So it's not going to be evenly distributed throughout the state, but I think you will continue to see in areas where Medi-Cal providers are hard to find and people aren't able to find Medi-Cal providers that are accepting new patients, and reimbursement is low, either because the state fee schedule is low or because the managed care plans doing business in that area keep it low, you will end up with people not being able to find providers for themselves, and the counties where they are able to elevate the fee schedule to make sure providers are in network, then you will have a better situation. The Department of Healthcare Services doesn't do a great job of monitoring and oversight of network adequacy for Medi-Cal managed care plans. And so I think there needs to be more dedication to ensuring access for people who are enrolled in these managed care plans than there currently is, to make sure that they can absorb new patient populations and make sure that the providers are getting fair compensation through that plan. Right. Well, I think we're at time. I'm happy to answer any questions you all have via email. So I'll just drop it in the chat here. It's on the first slide as well. But thanks for attending our kickoff National Public Health Week event. I hope you all have a good week, and thanks for joining.